Hi, I'm Dr. Huhn, and I want to explain what type 2 diabetes is. So generally type 2 begins in adulthood. Preceding type 2 diabetes, a person is generally going through several years of insulin resistance and impaired glucose tolerance, as it's officially called. So going back to the concept of insulin being a key that's necessary to open up doors to the cells and tissues of the body, type 2 diabetics have plenty of insulin for a number of years. It starts to wane in its effectiveness, however, because those keys stop fitting in the doors into the keyholes of the tissues of the body. So oftentimes people with type 2 diabetes have heredity to develop insulin resistance, or in our country, with a plethora of carbohydrates and calories that are so easily accessible, when a person develops a lot of belly fat, that fat is actually quite inflammatory and can result in insulin resistance in that mechanism. So over time, the insulin resistance can cause insulin deficiency because the pancreas is having to overproduce so much insulin that the beta cells that produce insulin get a little burned out, they get tired. And at that point, that's when we see the markers for diabetes like the hemoglobin A1C and fasting glucose levels rise quite significantly. So now I want to speak to the different treatments that we have for type 2 diabetes. So we find that there are at least 8 areas of the body that could have defects that cause type 2 diabetes. So if we speak to, say, the liver, if it's not getting enough insulin effect, it will start to overproduce sugar. One of the functions of our liver is to store sugar that's in excess and release it during times of emergency. The amount of sugar that it releases is regulated by insulin. So, in that, if the liver is resistant to insulin, it's going to kind of do its own thing, and often we see the higher blood sugars in the morning because the effect of insulin on the liver is defective. The pancreas obviously is a site of problems with type 2 diabetes. Beta cells within the islet cells in the pancreas produce insulin. So if there's a defect in its ability to produce insulin, obviously that's going to be a problem. There are other cells within the pancreas called alpha cells, and they can overproduce an anti-insulin hormone called glucagon. Glucagon, when we eat, should be suppressed, and that allows the insulin to work better. In type 2 diabetes, we often see an elevation in glucagon after eating, so that makes it harder for the insulin to work properly. The next tissue that we see a problem in is either muscle or fat cells, and they become resistant to insulin over time. And so the keys aren't working to open up those cells to allow the fuel to run our muscles or to store our extra calories in the fat properly. And so when that happens, then the sugar is going to be higher in the bloodstream. The kidneys are also a source of diabetes defect. We find that there are enzymes in the kidneys that are supposed to release extra sugar into the urine, but what is happening is that the abnormality causes the sugar to be reabsorbed back into the bloodstream rather than being eliminated. Our GI tract can also be a problem in that it forgets how to make certain, they're called incretins, or hormones from the gut, that tell the pancreas to release insulin, suppress glucagon, and to slow down how fast we're absorbing glucose out of our food. And lastly, the brain is also a center that can be defective in type 2 diabetes in that it doesn't realize that we're already full, so that we end up overeating when we're type 2. So the medications that we have to treat those different sites of abnormality pretty much track along what the defect is. So if the liver's releasing too much sugar, we use metformin to try to eliminate that or reduce that. When the pancreas isn't making insulin, we use insulin or sulfonylureas like glipizide that cause the beta cells to release extra insulin. And the alpha cell difficulty, if that is not being suppressed and it's making glucagon when we eat, there are medications that are classified as DPP-4 inhibitors and GLP-1 agonists, like your Januvia and Victoza medications. That straightens that out. The kidneys, in order to suppress their reabsorption of sugar back into the bloodstream, will be inhibited by SGLT2 inhibitors, like Invokana, Farxiga, or Jardiance. With the gut, to get those hormones back up to normal, we use the GLP-1s and DPP-4s also. And similarly with the GLP receptor agonists, that will tell the brain that yes, we are full, and so forth. So diabetes can start with one defect and then more defects can occur, so it's not unusual to start with 1 or 2 medications and have to add or change our regimen as time goes on. The main goal is to reduce the average blood sugar so that A1C levels are between 6 and 7%.